Okay, welcome everybody. This is the last event of the year for the Sleepout Sleep Education Series. So Hannah and I started this series actually because of our own struggle with my insomnia and years of dealing with that and just trying to get good information to help with sleep. This is a different topic on baby sleep, but we are lucky enough and very grateful to have an amazing expert here in Dr. Gradisar. I'll let Hannah introduce him in a second, but just in terms of the rules of the session, there are a lot of people here and there are a lot of people joining. There's a ton of interest in this. We probably end up doing another one. We want this session to be dedicated to you. So please do ask your questions. We just ask that you do them in chat. If we call on you, you can come off mute, but please otherwise be muted just to be respectful of everyone else's time. But yeah, please do interact with us and ask your questions directly in the chat. We'll try to get to as many as we can.
All right.
Hannah.
So hi, everyone. I'm Hannah. Some of you probably saw me posting in some different groups. I've chatted with a few of you. Really excited to be hosting this today. Feel free to drop comments and say hello in the chat. We'll be there and making sure to be responding there as well. I'll give you guys a quick rundown of what we're going to do. So I'll introduce Dr. Gradisar. He's going to give a quick presentation, kind of cover some basics that should answer a couple of questions that we've seen already. Leave your questions in the chat. We will call on you to unmute if you are comfortable and ask your question directly, and then we'll get those answered. Send out recordings afterwards and keep the conversation going after the session if we don't get to everybody in the hour. So without further ado, Dr. Michael Gradisar, who is spotlighted for everyone right now, he's an absolutely wonderful sleep researcher, professor, sleep educator. He's based in Adelaide, Australia, so it's very early in the morning right now. His background is actually in child psychology and sort of from there moved into sleep research across the entire lifespan from babies and infants to toddlers, children, all the way through adulthood. He's provided training to over 420 psychologists in Australia about the treatment of pediatric sleep disorders. He's also the founder of Wink Sleep, which is a sleep education platform. So you can become, he'll talk a little bit more about this, but basically certified in being a sleep educator and really up to speed on, kind of how this is happening, both behaviorally and also physiologically. And he's on the board of the Pediatric Sleep Council, which runs babysleep.com. All right, Michael, do you want to elaborate on your background and then jump into a presentation?
Yeah, I've got that slide actually within my presentation, so I can hit that when I get there.
Perfect.
And so I'm assuming I can share my screen.
You should be able to.
And you can see that all right?
Yeah, we're all good.
Excellent. Well, thank you, everybody. And thank you to the Sleepout guys. I think the curtains that they've invented, it's unbelievable. It hasn't been done already before, but well done on achieving that. And clearly, it's something that can really help baby sleep. It's something that I've always struggled with, is that when parents are having difficulties and you're trying to emulate sort of like the napping situation to be like the nighttime situation, but there's light coming through the curtains. So I think that's a really handy thing. So I only want to talk for a little bit here to give you some sort of background about me and I guess the way that I approach baby sleep, so we've got enough time to answer questions. So as an overview, I'm just going to go briefly about, just expand upon what Hannah just mentioned then, and then talk about baby sleep and really sort of talk firstly about biology, because that gets missed a fair bit when it comes to people being educated about infant sleep. And I want to just present some of our work that we've done with understanding what happened with baby sleep during COVID-19. Then I'll give you a bit of a framework, thinking about the way that we sort of approach baby sleep, and that can then lead into the Q&A. And then at the end, we'll sort of talk about other resources that, say, for instance, from my own website, where you can go, for instance, if you want to have more information about sort of like step-by-step things to do with baby sleep, as well as if you get sort of interested in this area, because I understand that sometimes people will come and approach this as like, I have a sleep issue, I want to have it fixed. But sleep's such a fascinating area that sometimes people want to actually throw themselves into it. So we've actually started to do some online training courses as well. So I can talk about those at the end. So as background, I've been a sleep researcher since 1998, which does seem like a very long time ago. So at the moment, we've got over 120 scientific publications about sleep. So we're really on the forefront of knowledge when it comes to sleep. I've been a clinical psychologist since 2002 and just specializing in sleep. I started with adult insomnia and also working with circadian rhythms, body clocks. And then I really sort of like worked my way down and started to do work with teenagers, school-age kids, preschoolers and infants, and established at my former university, a Child and Adolescent Sleep Clinic. I've been teaching at a university. I've actually just left the university a couple of weeks ago, so I can just throw myself into sort of like this translation of information. So I've been teaching at undergraduate level, but mainly at postgraduate level, really sort of teaching psychologists who are basically learning to become psychologists, and doing a whole host of workshops around Australia and indeed around the world. And now started up Wink Sleep, which is really sort of just trying to translate the sleep science, because what happens is that we sort of publish all these studies and it's been hard for people to access those studies. And even if you do, it's in this sort of jargon language. And we go to these sleep conferences, and yes, sometimes people do sleep in the audience at these sleep conferences, but most people are awake. But again, we're just sort of traveling in our own sort of science bubbles, and we're not necessarily been translating that in sort of language that's easy to understand. So hence why I wanted to do Wink Sleep. So firstly, I want to talk about baby sleep and the biology behind it, and really focus on the first 6 months, because I think this is really important to understand, because clearly when babies are born, you can have some that sleep well, but you really should expect that they won't necessarily sleep well. They'll be waking up a fair bit during the night. They're not matched with an adult's sleep. So the first component when we think about sleep biology is the biological clock, which is also known as the circadian rhythm. Now, there's different types of circadian rhythms. So the ones that we're most interested in as parents is really the sleep-wake rhythm. So when are they sleeping for the majority of the time? We hope that's at night. And when are they awake during that 24-hour period? And we hope that's during the day. But you can get other sorts of circadian rhythms. So you've got the circadian rhythm of body temperatures, for example. And that's actually what I did for my PhD, was to look at that relationship between body temperature rhythms as well as sleep rhythms as well. And what happens is when a baby is born, their circadian rhythm is not necessarily mature yet. It hasn't fully developed. And in terms of development, you have individual differences. So you'll have basically some babies that will be able to develop their circadian rhythm much more clearly at around 3 months, but the majority of them will form their circadian rhythm by 6 months of age. And that's really important, because that will let you know when is their biological clock saying it's time for nighttime sleep, and when is it basically saying I need to wake up and start my day. And when they do form, sometimes what's interesting, and it can be infrequent, but it still exists, is that when they do mature, they mature at a point in time where, say, for instance, an infant's body clock means that they need to fall asleep at 10 o'clock at night. And what will happen is, I guess a lot of parents will sort of go, well, some of these books will say, put your child down, your infant down at 7 o'clock in the evening, wake them up at 7 o'clock in the morning. And then they'll go and do that. And yes, the infant will sleep, but then they wake up about an hour later, and then they're awake for ages, and they don't fall asleep till 10:30. In those situations, it could be a case that the infant's body clock is actually developed, but developed late, almost like a teenager's in some sort of way. So it's very important to understand that there's a biological clock. We all have one, but it takes time to develop, and you can have individual differences when it comes to the development of that. Now, the second major one is called sleep homeostatic pressure. And so to make that more simple, it's just sleep pressure. And what that is that the more that you are awake, the more pressure you build up to fall asleep. So you would experience this yourself. So if you woke up at 7 o'clock in the morning, you will find that by midnight, maybe by 2 a.m., 4 a.m., you really have this pressure to fall asleep. And that is your biological natural process, which is known as sleep pressure. It's also related to deep sleep. So as you go into sleep, you're basically getting a lot of deep sleep initially at the start of the night, and you're releasing that sleep pressure. So it's this nice sort of relationship that it has, hence homeostasis. Now, for infants, it partially develops at about 4 months of age, but by 6 months of age, that's when it fully develops. So already what we've got here are two major components that influence sleep, that are sleep biology, and this happens across the lifespan. And by 6 months of age, that's when both of those processes should have fully developed. And so if you have heard that this is when this might be the better sort of time to try to intervene with sleep issues and try to help baby sleep, it's because those sleep issues, those basic biological processes should have formed by then. So the amount of time that the babies will spend awake during the night, that naturally decreases up to the point of 6 months of age. And then it basically remains reasonably stable. Now, probably 80% of infants will sort of sleep well by 6 months of age. And then you've got basically 20% that the parents or some sort of healthcare worker will say the baby probably has a sleep problem for various reasons. They have difficulty falling asleep at the start of the night, they need parental presence, or they wake up a lot during the night and they're awake for a lot of the time during the night. And what our approach is that it is perfectly fine for a parent to say, I think my baby has a sleep problem. You don't necessarily have to have a practitioner say that for you as well. So it's important to really listen to parents and sort of trust their sort of instincts when it comes to whether they think an infant has a sleep problem or not. So now what happened across the world last year was an incredible, massive experiment. And not only did it affect a whole range of different sort of well-being and our behaviors and so forth, not just for adults, but we were also interested in how that might have affected infants. And so we managed to work with a company called Nanit. And if you haven't heard of Nanit, Nanit have basically developed this camera that sits above the crib, and it measures through basically visual processors and a fancy algorithm, the sleep of infants. And so we were able to look at data that was being recorded prior to COVID happening, as COVID was happening, and people that were then starting to quarantine and thereafter. And because these cameras were running this whole period of time, we were able to match what happened to infants during 2020 versus what happened in 2019. So I'll try to walk you through this graph, but this graph here is basically looking at two different cohorts. The blue cohort is the 2019 one, and the red one is 2020. And on the y-axis, we're talking about nighttime sleep duration. How much did they sleep? And then we've got basically time or months across the x-axis here. So we've got from January, February, March, April, and May. So those periods of time when in 2020, we really saw this change occurring when we started to respond to this COVID-19 pandemic. Now, if you look at from January to March, they're fairly similar. There's not much white space between both the red and the blue curves here. But then shortly after March, you're starting to get some separation. And definitely by the end of March thereafter, you're finding that the infants in red were sort of having slightly more total sleep time. So as much as, there have been some devastating effects from COVID-19, there have been these odd silver linings that have occurred. And what has happened is that not only infants, but even adults have reported getting more sleep. In fact, I do a lot of work with teenagers, and teenagers have been able to get a lot more sleep now because they weren't necessarily going to school and they were able to sleep in. They weren't necessarily traveling on the buses and so forth. So this has also happened for infants. So for this particular study, so these sleep recordings were done via the Nanit cameras, and there were over 600 babies in this particular study. They were aged between 6 to 18 months. So we waited until all of those sleep biological processes had probably fully formed, and then wanted to see the sort of effect of external stimuli, which was these behaviors that we changed when we went more indoors. Now, the difference between the 2020 and the 2019 cohort, as much as it was different, statistically, it was a difference of 11 minutes. So that's not really that much, but that's 11 minutes per night. So therefore, if you look over a standard week, that's 77 minutes. So that's probably starting to add up to something a bit more meaningful. That's like a Pixar movie. And, if you've had gone to a Pixar movie and you've got a child that's mucking around or something like that, it takes a long time. So there is some meaningfulness when it comes to this particular finding when you look at it across a week. The other thing that we noticed is that, and it's only a small effect, but babies were also sleeping in. And this was the first sort of indication of a so-called social jet lag when it came to babies, that they were having this difference when it came to sleeping in compared to what was happening before. Again, it was only 10 minutes, but it was almost like very interesting in terms of this global experiment and what the effect was on baby sleep. So I've gone too far. here we are. So from the framework in terms of the way that we approach infant sleep, and this might help to sort of guide some of these Q&A sort of questions and answers that we'll go through. The first thing that we want to look at is really that there are safe sleep practices involved here, because I guess as a clinical psychologist working with sleep, probably the sort of two areas that I sort of get a bit concerned about are adults when we're doing insomnia work with them, because they basically drive 1-ton vehicles, and you can have accidents. There's this potential risk there. You don't necessarily get that so much working with teenagers and with school-age kids, but with infants, you can also have slight risks that also occur. And so it's really important to be able to instill safe sleep practices. We then look at the sleep environment, and I think, when it comes to really sort of doing this live Q&A with Sleepout have basically helped that situation by having these curtains that really have a great effect of emulating nighttime, even though it's actually daytime. We then look at circadian rhythm timing, and that's just not an approach that we do with babies. We do that across the lifespan, because if you try to do some sort of interventions, but the circadian rhythm is out of time with where it should be, then the outcome from doing those tips or those techniques aren't going to necessarily be so potent. So we always look at circadian rhythm timing first. Then we've got an approach for infants that we call bedtime fading, and that's really based upon that process of sleep pressure. So already you can see we're sort of identifying techniques that might match sleep biology. If we've gone through those, then we might then look at sleep training exercises. And sleep training is really not necessarily working on the biology, but looking at learning, because learning is another potent way of learning how to fall asleep, because people can also unlearn sleep. That can happen for adults, and that's where you get insomnia. But therefore, when you're doing something like cognitive behavior therapy for insomnia, that can help to relearn sleep. For infants, they can not necessarily have learned it yet. I mean, they're trying to learn a lot of different things, but sleep training is basically based upon learning theory. Once we've gone through all of that, a lot of parents probably think, oh, yep, now I'm going to sleep better because my infant's sleeping better. And sure, they do get improved sleep, but sometimes you can get this sort of residual insomnia. And so sometimes what we do is then we'll then help the parents with their insomnia and be able to sort of work on cognitive behavioral techniques to help them. So really enough from me. I'm really happy to now take some questions and hopefully answer a lot of those as much as possible. I do come from this from as much as possible an evidence-based approach. It means, I am a scientist. I try to think about the data, think about the studies and try to answer it. And sometimes I'll also match that with our sort of clinical experiences as well. So I'll stop there and see if you guys want to take over.
All right, so thank you so much, Dr. Gradisar. That is wonderful, and we've got some questions showing up in the chat already. We're gonna start with Diana's question at the top, which is, a 7-month-old seems to treat her bedtime like a nap. She'll wake and be up for an hour or more. How do I help with that? I'm sure this is similar, and at 7 months, probably at other stages early on, but for infants and babies who are sleeping like naps, treating their bedtimes like naps, how do you extend that sleep time?
Yep. So one thing that hopefully you've just learned from that talk is sleep pressure. So if you've got an infant that's around about 7 months of age, their sleep pressure should have already been developed. And therefore you can start to experiment, believe it or not, with their bedtime. Have you actually put them down at the bedtime that's ready biologically for them? And if you've put them down because the clock says, it's time for them to go to bed, and a number of people in the mothers group that I attend also put their child down at that time, you're probably not individualizing it for your own child. So if you say, for instance, you're putting your child down at 7 o'clock, but they're sort of up and down, and then they're falling asleep eventually at 8 o'clock, maybe their bedtime is actually 8 o'clock. So I would actually experiment with probably shifting things a bit later, because the problem that you might have is that learning theory kicks in. If you're putting an infant down at 7 o'clock, but they're not ready for bed, all of those cues and those indicators for sleep are now associated with wakefulness, especially if it's going over for a whole hour. But if you were to time it for sort of say, 10 to 8, closer to when they're actually falling asleep, you've only got a distance of 10 minutes. And that's when you can have greater association with those sleepy feelings and also those sort of cues at bedtime.
Yeah, it makes sense completely. Just like adults, every baby can be a little bit different there. Another question asks about sleep practices from day one. I'm kind of curious to hear for your clients, like what are some of the bigger misconceptions? Like what are one or two things that you find yourself always saying to clients that end up making the biggest differences? Because I think that's what this question is getting at. Like what are the one or two key things that make the largest difference generally?
Yeah, I think, I mean, if a client's coming to see me, they've tried a lot of things,
Right.
and they probably also, I mean, dare I sort of say, and this might get a bit controversial, but, you know, we've just gone through COVID, and it's been fascinating looking at how much people adopt scientific information from scientists. And this is something not new to me, because in this particular space, when you're working with infants, I've been doing this for 15 years. And definitely when we were doing a study that I haven't necessarily even talked about, where we were trying to test this whole concept that sleep training is harmful, it was incredible to sort of see back then how many, like for the first time, how many people were not really adopting, sort of like taking information from scientists. And the way that they were sort of interpreting science. So the biggest thing that comes through for a lot of families is by the time that they come and see me, they've heard that letting their children cry is going to lead to all of these terrible, awful things. And I'm at least in a sort of fairly good situation where I can say, well, look, we did this particular study. We were the first people to actually test this. And the whole notion, the whole hypothesis is, if you let your infant cry and do sleep training, which is going to involve crying, that's their way of communicating, saying, hey, why is this changed? I don't like this. Then the hypothesis is that will increase their stress levels and therefore their salivary cortisol expression. That's how you objectively measure it. What then would happen is that leads to later emotional dysregulation and so forth, behavioral issues, and then attachment issues with the parent. So that's the biggest thing that comes through when it comes to this sort of misconception, because that's a theory. And we tested this theory. And the first step in that theory is that you'll get these increased levels of cortisol. Now, people have to understand cortisol works in a couple of different ways. You can get an instant cortisol response. And yes, it can go up, but then it settles and comes back down. That theory is based upon animal studies and also studies where children are in deprived environments. So for instance, they're without their parents, they're in basically adoption centers, as well as you've got people that, children that are in chronic violent situations. So they're on 24/7 alert. We're talking about chronic stress, not just this acute stress that happens when the infant is separated from the parent at night. And so if you're going to truly test this, you have to look at cortisol levels, not just at the time that it's happening, but is this basically increasing their overall levels of cortisol? And so like what we did, you measure it over a couple of days. And what we found is that we did not see this increase in cortisol levels. In fact, if anything, we saw a decrease in cortisol levels from doing sleep training, if I have to sort of go that far. So therefore, later on, when we measured their attachment, we didn't find that there were any issues with attachment compared to a control group. And likewise, we didn't see any differences with their behavioral outcomes or their emotional outcomes. So ours was I would say the first test, and there's been other studies that have come out that have basically showed similar findings. So at the moment, we don't have strong direct evidence to say that sleep training causes harm. We don't, in fact, if anything, when I've looked at this literature, I've really had to look at it, you know, has there been a death, an infant death due to sleep training? I can't find one. Yet, if you look at when infants die, when it comes to sleep, and it is rare, it is because of bed sharing in Western societies. That's where we actually see mortality occurring. The other issue is when parents have been just so sleep deprived and so desperate seeking services that they've actually harmed their baby as well. And just on saying that, I know that it can actually be more common than a lot of people will fess up to, but a lot of parents can have thoughts of harming their infant. You know, these are thoughts, but acting upon them is incredibly rare. Okay. But it's more likely to happen when the parent is depressed as well. And depression increases when you're not sleeping well. So it's not necessarily one or two misconceptions. That's the biggest one when it comes to infant sleep.
Right. So that's super good to know, and definitely something that I think is sensitive, and a lot of what we've seen, it comes up, and there are so many different opinions and different approaches to it. So that's you know, not only super good to hear, but also just like knowing that it's important to be getting your own quality of sleep, so that to the extent that you can. There have been a couple of questions in the chat and beforehand about babies having trouble sleeping without being held, without being in a bed sharing situation. They sleep totally fine until you put them down in a bed, and then they're up instantaneously. How do you work through that and get them so that they're comfortable sleeping on their own?
Yeah, I mean, that definitely, if people do want to help with that, they really need to probably see someone to do a tailored approach, because there's so many factors to it. Like I've already mentioned in that previous example, if you're putting your infant down at 7 o'clock, but they're not ready biologically to fall asleep, then they're going to go into a light sleep. They're not necessarily going to go into a deep sleep. So the first thing that I would say in the approach is really have a look at when biologically you believe that they're going to fall asleep. And that might involve just playing around with their bedtime initially by just changing it by 15 minutes. And when you do this, say for instance, if you're putting your baby down at 7 o'clock and things aren't necessarily working, try 7:15 for a week, see how that goes. Do you notice any sort of differences? And if you don't yet, try 7:30 and try that sort of approach. What you're doing is you're biologically allowing your infant to build up that little bit of sleep pressure, and then they might have a greater chance of not only falling asleep, but going into a deeper sleep as well. So that's one sort of thing to think about. And when it comes to infants, what's probably happened if they really find that they need to be able to have that physical presence is that they've been learned to sleep that way. They've been held that way. And this is not to sort of evoke any sort of guilt. This is just to try to understand what are the reasons or the associations really for my infant sleeping. And therefore, what it means is if I want my infant to be able to sleep without me, I need to gradually, if I can, try to sort of move that away. So what we would suggest is that, say, for instance, if we had a parent that came to us and sort of said that they are bed sharing and they've got the infant sleeping with them, that's the first thing that we have to do is stop that immediately, because that shows the greatest risk of death. What we will suggest is that room sharing is perfectly fine in that sort of situation. And so as long as you've got an appropriate sort of crib that you can have next to the bed and start to really still have that physical presence, putting your hands on there and so forth. So instead of necessarily holding them completely tight next to you, being able to sort of have your whole arm on them as much as possible, and then your hand and so forth, and then just gradually sort of tapering that away. But it needs consistency is one thing. It needs to be done every single time that the infant is trying to sleep. And that means there has to be a lot of motivation to be able to do that, and from what we hear from parents, their motivation sometimes gets to the point where they say, I can't keep going on the way I am. Something has to change. And if you get to that point, that sounds like then you're ready. But you might be ready, but what we're noticing is that a lot of parents need support to do that. Doing this alone is very, very hard. They need to sometimes just say, okay, I'm ready. And, can we work as a team with, say, me and my husband? Can we also maybe just even like what will happen is a lot of grandparents will see how these how their own adult children are suffering because of sleep issues, and you'd be surprised how many of them will actually come in for a night or two to sort of help them with this sort of situation as well. So it's not just about the technique, it's about the motivation, but also making sure that there's supports to sort of really carry this through, because it's changing sleep from bad sleep to good sleep. Even with adult sleep, when it comes to adult insomnia, you have to do things that are challenging, they're uncomfortable. And if you go through that uncomfortable phase, you'd be really surprised how quickly the stuff can work. In the sleep field, for instance, it only takes 4 to 6 weeks of improving adult sleep. Whereas my colleagues that work in eating disorders will sort of take 6 months to help people with eating disorders, or PTSD, it might sort of take 3 months. So we're very fortunate that sort of pain is relatively short-lived. So that's just some sort of insights into sort of our approach.
Yeah, and as somebody who's actually done some sleep restriction related to insomnia, I could definitely talk about that short-term pain. It's painful, but very, very helpful. Lots of questions about sleep environment in particular. So you've already talked about darkness, but questions about using a white noise machine is kind of playing into what you said before, that people are trying a lot of different things, which makes sense. White noise and temperature in particular, people are wondering, should we sleep a bit colder? Could my baby be waking up because they're too warm?
Yep. Okay. Those are two great ones. So when it comes to any sort of noise, think about this in terms of what's called learning theory. Again, so learning theory is basically saying what is happening in the environment that the baby associates with those sleepy feelings and falling asleep. So if you have a white noise machine on, then the baby will over time learn that with that induces sleepiness. That means if you don't have it present, it's going to almost have a bit of an opposite reaction. So if you find that your baby, if this works for your baby, in some ways that can be fine. And this is why you should always sort of see someone sort of one-on-one and a tailored approach, because you could have people that aren't necessarily working and they're able to do something like this. Whereas if you've got people that are working and they're like, no, I just need my infant to sleep, I can't really have bad sleep right now, you would continue using that white noise machine. So I would say that if you are using white noise machine and it's working, that can be okay. But when you get to the point that you need to then stop that, and I don't use white noise machines myself, but you might want to then start to taper it down again. So it's a case of trying to decrease the volume. And if you match that basically like, what you were saying about sleep restriction therapy, which is similar to bedtime fading, if you can sort of build up the baby's sleep pressure around that time that you're actually tapering the volume down, you're actually increasing the baby's sleepiness and the likelihood she will still fall asleep if the volume is coming down. So that's one example when it comes to sound. The temperature for most of us humans, if you are in hot climates, warm climates, it's much harder to fall asleep. So from my PhD work, what happens is that as we are on the approach to sleep, we need to cool our what's called body temperature down, our core body temperature. In fact, our core body temperature is the lowest when we're sleeping overnight. And the way it reduces the heat is to really let a lot of the heat out. And that mostly comes from like our face, our hands and our feet. And so what will happen is that in the evening, as we're approaching bedtime, we'll get a lot of heat that's escaping from the inside of our body through our hands and feet, and that's helping to cool us down. But to really help that, we need to have a cold environment, because heat basically transfers from a warm environment to a cool environment. So you need to have basically ambient temperature being cool. You've also got to be, this is why it's always recommended as well not to, for one reason, not to have necessarily quilts, for example, or doonas, I'm not sure what you call it over in your part of the world, on babies, because it's actually trapping heat. As they're trying to sort of release it, say for instance, from the feet, you're actually creating a bit of heat around the body of the infant, notwithstanding the fact that, the infant can get wrapped up in the quilts and you shouldn't have anything like that. So definitely try to make the environment cool as possible. And certainly if you are using noise and it's working, go with it for now. But when you're at a point of trying to change that because you realize you can't take the white noise machine everywhere with your infant, try to taper that down, but then try to sort of bring in that sort of bedtime fading technique and just sort of get them to sort of go to bed a bit later by 15 minutes to build up that sleep pressure.
That is lovely. Thank you very much, Dr. Gradisar. A couple more questions in the chat about pacifiers, loveys, basically different things in cribs to help babies sleep. When is it safe to introduce those? And then on the other end, at what point do you start weaning them? How do you go about that process when it seems to be kind of the make or break?
Yeah, and anyone that's probably got two infants or more knows, some can be chalk and cheese and some will need to have a pacifier and others won't. So really, again, this is probably a tailored approach. So this information I guess I'm providing is fairly general in nature. So you might sort of find that like we did with our son, one of our sons, is that one son didn't need a pacifier whatsoever. Another one really needed it, and really early on. So in order to be able to help us adults function, we basically went with that pacifier. Now, you've got to be a little bit careful, because what can happen then is that you'll probably notice that the pacifier will come out during the night, and then they won't be able to find it and put it back in, and then they'll sort of cry, and you have to get up and provide it. And you probably may not have realized that your baby has trained you to put it there. So I remember clearly with an example, and some people might relate to this, is that I remember when my first son was starting to cry, I remember thinking, oh my God, I better get up quickly and get that pacifier in his mouth, because if I don't, he's really going to wake up, and then I'm going to be awake for another hour trying to feed him. But what happened is, by responding to him as quickly as possible, the frequency of his cries started to increase a lot more as well. So that's happening because of learning theory. He has basically learned that if I cry, I'm going to get the pacifier in my mouth pretty quickly. I also learned if I get up really quickly, I'm going to be able to get back to sleep, and sleep is quite a powerful reinforcer.
Okay, perfect. So,
and we're back.
We'll pick up where we left off. I mean,
yeah, so I had one question before we left off, which was basically around the timing of naps. There was a lot of questions about that, and whether to go with the regular windows or whether to go with a biological clock. I think wake windows or biological clock around that.
Great question. One thing that we really, I think, that helps parents when they're trying to sort of understand this concept is that we use what's called a sleep diary. So you could actually go to our website if you want, and download a sleep diary for free. So that's winksleep.online, or just type into Google Wink Sleep, go to downloads, and you can get a sleep diary there. And if you print that out, you can start to sort of log your baby's sleep. And what can then happen if you do that for a week, and this is something that we do for not only infants, but also for adults and teens and kids and so forth, is that you can sort of see the zones of sleep that are more likely to occur for your baby. Because I think when you're sort of doing this night after night, it's really, or I should say day after day, it's a little bit hard to sort of see where the timing is happening. So once you do that, then you can sort of go, okay, well, it looks like my infant needs 3 sleeps, and they seem to be roughly around these sort of times. That's usually what will happen. Or it looks like my infant needs to have sleep around sort of these 2 zones, one in the morning around this sort of time, one in the afternoon around this sort of time. And so that's really the first process in understanding where the best time is for the naps. But then what we like to do is really flip that around and say to parents, now have a look at the sort of white space. Look at when they wake up in the morning and how many hours it takes until they get to that first nap. Then after the sort of between the first nap and the second nap, how many hours are they awake? And again, how many hours are they awake from their final nap to when they fall asleep? This is really, again, teaching about sleep pressure. Sleep pressure is about the longer that you're able to wake, the greater the sleepiness when you go to have that nap, or you go to have your final sleep at the beginning of the night. So it's a bit like science, which obviously that Zoom bomb guy didn't like. He doesn't like hearing about science. Although, you don't eat a lot of hot sauce, science tells us that's bad. So you would need to sort of do this individually for your baby. And the first thing you do is you monitor it, you make an assessment of it. That's exactly what we do. And hopefully if you understand the theories, and in this case, the theory is about sleep pressure, looking at when they nap, when they're most likely going to nap, but then flip it around, look at how much time they're able to spend awake. And when they do that, you want to really have a look, especially when it comes to their nighttime sleep, how long can they be awake for before they actually fall asleep? You want to be able to sort of have it just slightly greater between the end of their final nap to when they fall asleep at the start of the night. They have that as the greatest time where they can really stretch it and be awake for longer, so it really helps them fall asleep.
So yeah, it goes back to that sleep pressure and trying to get that build up, which I think is sort of similar to what you end up doing later in life, but just tailoring it to their schedules. On that note, a couple questions in the chat on sleep training timing in their broader life cycles. So one question was, when their circadian rhythms don't really start developing till 5-6 months, is there a benefit to starting at 4 months? When is the best time to start sleep training? How can you support them before they start to develop those circadian rhythms, et cetera?
Yep. Okay, that's good. So I'm going to answer that in 2 parts. And again, this is answering it in terms of theories, and it's answering it in terms of looking across the broader lifespan and what happens with sleep. So when you're doing sleep training, that is based upon what's called learning theory. So the whole idea is that the response that the parent has, usually what will happen is that the parent will put them down, and then the infant at some point will cry and the parent will go to them. So that what you're doing is you're systematically just trying to just delay that response ever so slightly every single time that they cry during the night and consecutive nights. That's based upon learning theory. So that if you're not having that sort of gradual delay of your response, what's happening is you're responding frequently. So the baby has learned, if I cry, then I'll get that thing that I really need at this point in time. Now, the thing is, when you're doing this night after night after night after night, you're also working on this baby's sleep biology, because they're not getting much sleep and their sleep pressure is building up. And what we constantly hear from so many people, so many practitioners around the world, is that when you do something like sleep training, on average, things will happen at about sort of the third or fourth night. That's when things will kick in. And that sort of makes sense to us, because when you're doing sleep training, it occurs in terms of learning theory, and eventually the biology kicks in and that sleep pressure kicks in. So if you, obviously you've heard that sleep pressure will basically develop by 6 months of age, but I did also mention that you can start to see the development of sleep pressure around 4 months of age. So if you're absolutely desperate and you feel like, okay, I can't wait another 2 months, and I completely understand that, because, you know, if you are suffering from bad sleep, waiting a week or even 2 weeks is just way too long. So you can certainly do it. Now, when it comes to learning theory has been applied to even our white blood cells, our immune system. Our immune system can even learn. So basically, when a baby is born, yes, it can learn. The thing is that we want to ensure for parents that they also have the biology behind them. So I would say that there is a possibility, if your infant is 4 months of age, that you could also start to attempt the sleep training. When you do this, it's again making sure that you have consistency, that you guys are motivated, that you're prepared, that you have plans, that you work as part of a team. You try to get people on board to support you. When you realize that, you know, it's too much for you, that you can sort of like tag out and someone else can come in for you and take over. And it's more likely to increase the chances of success.
It's awesome. And yeah, we're definitely, we've got more questions than time, so we're going to ask a few more. We will end up creating a Facebook group, guys, for tons of AMAs like this one. So we'll obviously have another event, especially because this one was unfortunately interrupted there. One question that I'm seeing kind of repeatedly, so this more particular, is about a 9-month-old routinely waking up every 3 to 4 hours at night. And then the question that I find interesting here is they're saying, is this just a developmental phase? So could it be your infant wakes up every couple hours and there's not actually not doing something wrong, or there isn't a problem? It's just actually they're just going through a phase, and in some cases that's normal.
Yeah, it's interesting because you hear often about sleep regressions, which you don't necessarily have that in the scientific studies. But one thing that the scientific studies have shown is that when infants go through some sort of developmental milestone, say for instance, when they learn how to sort of stand, sit, crawl, and the crawling can happen around that sort of like 9 months of age, for example, that's when you can see a change in sleep. And that's when you can see that infants are more likely to wake up. And so one aspect of learning theory is something that's called an extinction burst. It's a fancy sort of term, but what that means is that what's happened is that the infant has possibly learned to sleep, but then they'll have this trigger that means, and it's phrased as an extinction burst, when they can start to unlearn sleep. Now, it's usually applied for sort of infants and for preschoolers, but you can also use the same sort of principle for people with insomnia, because usually with insomnia, you'll have some sort of trigger that will set off the insomnia. And once that trigger has sort of settled down, then eventually, you know, people will return to good sleep. Even people with chronic insomnia that go to do CBT for insomnia, they've learned the skills, they'll get to better sleep. But then there'll be some sort of other trigger down the track, and that'll be almost like an extinction burst. So usually, so I guess the summary of that is usually it might be tied to some sort of developmental milestone achievement. It might be because there's some sort of other trigger. You know, sometimes clearly what can happen is that infants often get sick, and that can then be a trigger to unlearn sleep. So what you can do is you're applying the same sort of principles. If you use something like sleep training and it works at 4, 5, 6, 7 months of age, but then again, you see this unlearning of sleep at 9 months of age, you use what works and you reapply it. When we looked at our data of using that technique that I'm sort of hinting towards, which is called bedtime fading, which is basically trying to sort of have a consistent time that your infant wakes up in the morning, but playing around with their bedtime and finding where the ideal bedtime is. That was really helpful for infants falling asleep quickly and less crying at the start of the night. It wasn't as fantastic as the wakings during the night. The technique that was far by the best for reducing the number of awakenings and the amount of time that infants were awake during the night was sleep training. So often look at what you've done in the past, you know, did it work? And sometimes you have to just re-implement that and understand that sleep is sometimes a canary in the mind. You know, if something's going wrong, if we're stressed or something like that, you have some sort of medical condition, you go through something like a pandemic, you know, you're going to have these things that will trigger sleep and trigger insomnia and sleeplessness. So you bring back those skills and hopefully those skills are based upon knowledge from scientific information.
And that scientific information is a very great lead in to our final question. We're getting up to time. But a couple of questions about just books, resources, different places online you can go to find information on infant sleep training. I mean, obviously you're a great resource and there's probably a mention of Wink Sleep in here. But yeah, where would you go to find this sort of help?
Yeah, and definitely you want to go to places that are based upon credible sources. I mean, when I say credible sources, I'm talking about people that have done the science behind this, or they've consulted science about this as well. So say, for example, babysleep.com, and yes, you know, I will have a conflict of interest there because I'm also on the panel there, but that's a collection of sleep scientists, baby sleep scientists, people that also practice with infant sleep, toddler sleep, and so forth. That's got a huge amount of resources there. It's got frequently asked questions in video format as well. It's got links to different books as well and different resources. So that's a great place. Definitely, I'll have to say, always look at safe sleep practices as well in your country. Like type in safe sleep practices and hopefully Google will know where you are. You haven't got some sort of weird VPN. And you'll be able to find out that sort of information. Like in Australia, for example, we've got something called Raising Children's Network. And what they do is that they're a government-funded organisation who provide evidence-based information. And what they will do is a quality control. So they'll consult with experts and have a look at the content, say, is this still up to date? Is there any changes we need to make in line with any sort of changes in the evidence? So those are some examples. Where you can get free content. And I think that could be quite good in helping a lot of people broadly. And if you're still finding that you have some sort of issues in terms of books and so forth, so we have basically what we call an ebook. It's called Infant Wink. It's at winksleep.online. If you go to shop, you'll find it there. And because you know, we're doing something with you guys at Sleepout, if you use the code SLEEPOUT, but actually, in fact, I'm going to type it in the chat because that's going to be a lot easier than me reading it out. If you use this at the checkout, you'll be able to basically get 15% off of that. And I'm also going to put in the chat, if you're interested in just learning about this sort of stuff, we've also got online courses that you can also take up. And if you use Sleepout 20 for the online courses, that will allow you to get 20% off of those online courses. But certainly, I would say it'll get to a point where you'll get free information. Maybe you'll pay to sort of get some more specific information. And I will say that infant sleep is designed to sort of tell you step by step what to do. And we don't go straight into sleep training with Infant Wink. We're talking about basically some of those biological processes. The first thing that we do when we see parents, we will go for bedtime fading. It's a much gentler technique. It does work on primarily the start of the night and really help that. It can help to understand the timing of those naps. And then if there's still any residual problems, then we take parents through step by step what to do with sleep training based upon our scientific research. That particular study where we tested whether sleep training resulted in any sort of harm. But if all else fails, definitely have a look for some sort of hospital that has some sort of pediatric sleep disorders unit. In particular, someone that's probably got some sort of medical background or a psychologist background who can really do a tailored sort of approach, have a look at what's happening for your infant and go, okay, now that I've got all of this information, these are the things that are quite well suited for you.
And that'll close us up. Just a huge thank you, Dr. Gradisar, for being willing to join us and all that helpful information. We will definitely continue this. There's been a lot of interest in this one in particular, and we will definitely do this again. We'll send out the recording to everybody, so you will get that. We'll get the link to the Facebook group where we'll be hosting similar events. And just, yeah, thanks to everybody for joining. I appreciate it.
And thanks for inviting me, guys.